Okay, good morning, everybody. Or is it good afternoon? It's actually good afternoon. We're just waiting for everybody to come in. I think we're probably got a few more to come, but we might just start because we're already at 12:37. So I am wanting to say hello. Hello, everyone. Welcome. I'm Catherine, as I think most of you know. I'm the CEO of the Baird Institute. Thanks so much to all of you for joining us today. And of course, thank you as always for your support. I'd just like to introduce you to a few of our team who are here today. We have Daria Vallada, he's our data research assistant. We've got Lisa Turner, she's our newest recruit. Lisa worked in the cardiovascular clinical trials and has now moved to working with us as our engagement manager. So I'd like to welcome Lisa. And then of course we have our presenters today. That's Associate Professor Sean Lowell and Professor Paul Bannon. Sean is an academic in the Faculty of Medicine and Health at the University of Sydney and a consultant cardiologist at Royal Prince Alfred Hospital, where he is the Director of Acute Heart Failure Services. He's also Director of the Sydney Heart Bank at Sydney University, along with Paul Bannon. Paul is the Chair of the Baird Institute. He's a cardiothoracic surgeon of international standing with clinical appointments at Royal Prince Alfred, Concord and Strathfield Private Hospital. At Royal Prince Alfred Hospital, Professor Bannon is the co-chair of the Institute for Academic Surgery and director of the Robotic Training Institute. At the University of Sydney, he holds the professorial chair of cardiothoracic surgery and the Bosch Chair of Surgery. He is also the current head of the discipline of surgery for the Sydney Medical School and the academic director of the Translational Research Facility at the Charles Perkins Centre. Our webinar today is on hypertrophic cardiomyopathy. We're wanting to know what causes this form of heart failure and what therapies can be developed to prevent or reverse it. Our aim is to obtain the unique molecular signature of HCM, which we hope will lead to first-in-the-world discoveries of the causes of this form of heart failure, and thus what therapies can be developed to prevent or reverse it. The Sydney Heart Bank, that's located at the University of Sydney, is the first human tissue myectomy repository in Australia. This large and comprehensive biobank will facilitate the identification of the molecular mechanisms that cause HCM, and Sean will be talking more about this today. Just before I hand over to Paul and Sean, just a little bit of housekeeping. All attendees' microphones have been muted just to be sure that the webinar goes smoothly. If you have any questions throughout the presentations, note them down to ask at the end, or just use the Q&A button that's at the top of the webinar page to send a question through during the presentation, and we will get to all questions at the end. So I think over to you, and Paul's going to be the first one to talk today. Paul?
Thanks, Catherine. Welcome, everybody. And thanks for the opportunity to talk about well, not only an interesting condition, but quite a difficult condition to manage. I've been involved in the program from the surgical aspect, from the surgical side, of dealing with hypertrophic cardiomyopathy for more than a decade. And it is interesting in the sense that surgically, there was only one treatment at all for the condition. During my training, and that was almost 30 years ago, and surgery has come back into favour, I guess, as the most preferred treatment, if at all possible. So I'll go through that and just touch on some of the other treatments of hypertrophic cardiomyopathy and try to explain essentially what it is and why it needs to be treated. But really, the interesting part of the session will be what Associate Professor Sean Lowell talks about, and how we can try to work out the fundamental cause of the condition and what future therapies could be developed to prevent it, and so people hopefully won't require surgery, and that's always the objective. So I'll get on. There are a few images here of surgery, so I hope that doesn't upset anybody, but it is really I think it's quite critical to understanding the condition. So this is just basically some cartoons of the condition. So this is a slice, various slices of the heart. And if you look at the top left image there, that's essentially normal. So you've got the image on this is the right ventricle here, if you can see my pointer. And this is the left ventricle, which is the last chamber of the heart, of the four chambers, which then ejects the blood up through the aortic valve into the aorta and therefore to the rest of the body. You can have hypertrophic cardiomyopathy, just means thickening of the heart muscle. It occurs almost everywhere, but Sean will talk a bit more about that. What we focus on in surgery is the condition here, sort of, it's what we call septal or basal septal hypertrophy. So you can see this wall here, which is interventricular septum between the right ventricle and the left ventricle, rather than being fairly thin at around 8 to 10 millimeters, can reach thicknesses of up to 40 millimeters I've seen in some of the patients that we've managed. And this clearly causes an obstruction of the blood trying to get out through the ventricle into the valve. And so that limits people's exercise tolerance often quite severely, to the point where sometimes they have trouble even getting up a flight of stairs, or some patients have said to me they can't walk down to the front of the house to get their letters from the post box. There are other forms, mid-ventricular, so further down, and apical, which can be harder to treat. But generally what we see surgically, at least, is basal septal, so I'll focus on those. This is an echo evidence. I think it will keep looping to demonstrate that this is of a real patient. And so this is, again, this is the left ventricle here, and there's that valve that I said is right through there, not this one up here. And you can see this is the thickening, as you can see quite clearly. And you can see that tract narrowing down markedly and affecting the other valve here. That's called left ventricular outflow tract obstruction. So in other words, the blood's trying to get from there to there, but it's going through this incredibly narrow path. And that not only stops the blood from getting out, but disrupts the function of this other valve called the mitral valve. The image on the right is really just a measurement of that flow, or that turbulent flow, or increased velocity of that blood flow through there. But that's what we're trying to fix. And these patients can be really quite markedly affected by this. Oftentimes they can have little or no upset to their daily life if they're just sitting at rest, but as soon as they start to exert themselves, it's a completely different story, as your cardiac output needs to increase to accommodate, and it simply can't. So just the basic breakdown of the management here, of the different sort of ways we can deal with it. There's medical therapy, and that's with essentially drugs, so different forms of medications, beta blockers, calcium channel blockers, what we call disopyramide. And there's a new one on the scene called mavacamten, which I'm sure Sean will speak about, and that's quite promising. However, it seems to, one of the issues with that seems to be it has to be long-term treatment, and the condition recurs once the drug is stopped, and regular monitoring has to happen. And there's a theoretical, but this is Sean will correct me on this if incorrect. There's a theoretical risk of long-term heart failure. So nothing is perfect in here, but that medical therapy is the first line, and if that is not working, then we'll look at what we call septal reduction therapy. So in other words, some way of getting that thickness down to a more normal level. And for many years, what we call alcohol ablation was done. That's percutaneous, so if you like, coronary stents rather than heart bypass surgery. So, but effectively what we're doing there is, if there is an artery supplying that area, interventional cardiology can inject essentially some alcohol into that area of the heart muscle and basically cause a controlled heart attack. And that will over time reduce the thickness of the septum, but clearly, as we'll see a little later, not as effectively as surgery, which is referred to as septal myectomy. So we'll touch on that in a minute, but first, why can't I progress? Here we go. More recently, if anyone's of interest, has any interest in this, there's a very good article that I was very kindly included in by the group at the Mayo Clinic, where I honed my skills on performing the surgery, and which covers the history of the treatment of septal myectomy and all the other treatments over many years, 60 years of practice. And that's a very thorough read if anyone's of interest there, but that's it covers most of the things we're talking about. So when we're talking about the septomyectomy or the surgical access, it is open heart surgery. So any of you who have had open heart surgery, you'll recognise this, but this is exactly what we're talking about. We do have to go through the sternum, the breastbone, and to get access through that valve, as I talked about, to get access to that septum. So it's not, although you will see people talk about minimal access approaches to this, as I'll demonstrate a little later on, people that do a number of these would suggest that that's not appropriate. You really do have to get good access to treat the condition properly. Now this starts off as a bit of a cartoon, as for the Mayo actually, cartoon treatment of it, but this we'll get to some surgery as well. This is what we see looking down through the valve, through the aortic valve, and looking down at the septum. So this is, I'll stop it at various points. But this is, you can see the point, that's that interventricular septum between the two ventricles. And what we're going to do is we're going to make a cut in there and create a channel. So that's that thickening there. And this is the knife coming down through, protecting the mitral valve that I talked about, but working very carefully through the aortic valve. And although the lighting is probably a bit dull there, you'll see in a little while it'll improve a bit. You'll see some a bit more imaging. So there you go. That's the heart muscle being cut. That's literally what we do, cutting out a channel in that outflow tract to get to that, to allow that blood to come out through there. So we'll see that coming out now. We have to be very careful that we're not damaging other structures. Be careful that we're going too deep to make a hole in the wall. Careful that we don't damage that aortic valve or the mitral valve behind it. This is the point about full access. A lot of problems in the past have been caused by doing inadequate resections, which we'll look at in a second. And so this is where we're applying a bit of pressure to the heart from outside. You can't see that. And digging further down. So you have to go all the way down. It's usually as the piece of muscle that's been taken out, and suddenly the obstruction is being relieved. And this is the push down. You'll see this in a second, where we apply a bit of pressure. I think it comes up in a second. Applying a bit of pressure to the heart. This is why minimal access or small incisions to do this really just doesn't work. You need to be able to push the rest of that septum or that wall down into view to make a further cut. And this is actually what results in good management overall of these patients. And I will make a note that this heart muscle that Sean will talk about a little later is sent off to pathology for categorization, but also sent off to our biobank for the research, which Sean will speak about. And I think that's key. We do focus on managing our patients surgically or whichever way is appropriate, but also trying to incorporate them all to provide research in some shape or form, whether it's data collection, whether it's follow-up, whether it's patient feedback or biobanking to help us with our basic research. I think this is absolutely critical, and I'll let Sean speak about that in a moment. Now, I think there's probably not a great deal more to be gleaned from that now, other than I'll just focus on that. You can see that big wide channel that's being cut through there now. And I think you'll see that we'll put the valve back in place, make sure that everything's still intact, and then finish up and take the patient off the heart and lung machine. So what I was referring to about that full access, if you don't get good access to the heart muscle and apply that pressure as demonstrated here, is what we call incomplete resection. And so the first cut has been made there, but there's been a divot, but you can see the bolt still there. That's the mitral valve there. So there's still be a problem. We're very careful about how we do this. We do very complete resections as far down towards the end of the heart or the apex as we can, and we measure directly on the table to make sure that the pressure gradients or the blockage is relieved before we wean from the heart-lung machine and allow the patient to return to intensive care. And I think that's been the absolute key to the success of the program. Very busy slide, but really just to give you a background where surgical myectomy fits in the whole spectrum of heart surgery. The top left of the blue and the red columns shows the growth, if you like. This is from the Mayo Clinic, year by year out to 2019, this one is, but there's no reason to think it's changed, or Mavor-Campton may change it. But the red is what I refer to as the alcohol septal ablation, so the interventional treatment. And that's really remained constant, but the surgical application has risen every year. And I think that's because of the recognition that the surgical approach is by far the best approach. If you look at look at the top right, this is an all-cause mortality or expected survival. What this is showing is that if patients have the surgery, the myectomy, they live as long as they should have, which is critically important. So we do feel now that it does actually improve survival, not just symptoms. If you look at the bottom right, you see that patients that have had the myectomy, that's the surgery. Patients that are obstructive, if you look at the bottom curve, this is survival again. If they have an obstructive form, but they're not operated, they do very poorly over many years. You see the graphs change very quickly. The non-obstructive patients don't do as poorly as the non-operated obstructive patients, but they also do poorly. And that's another reason for research that needs to be done. Because if patients don't have an obstruction that I can relieve surgically, they still need to be treated in some way. But clearly, this is a terrible problem for these patients. They just don't do well unless we can treat them in some way. The bottom left corner is an important one. Bottom left graph is an important one because it tells you where the numbers of surgical septal myectomy fit in with all the other heart surgery operations. So most heart surgeons will do lots of bypass grafts and valve replacements. I do a lot of aortic surgery as well. But septal myectomies aren't that many, despite the incidence, which Sean will talk about, in the general population. And that's really important because it means that people who do the surgery need to have the experience and not just doing one or two a year, which is quite common. And I think that's quite critical, and that's borne out by the evidence. And this is a very good paper, again, by a consortium of all the major groups around the world that do septal myectomy, and the impact of hospital volume on outcomes, which I think most people of you would understand is important. This is using the US database. They had almost 6,000 patients, but frighteningly 500 centres and 900 surgeons performing septal myectomies. And this is the centre distribution. So 75% of the centres doing septal myectomy did less than one a year, right? Less than one a year. Only 2% did more than 10% a year. And I suppose so I'll just go back to that. But thankfully, about 46% of patients were treated in those centres that did more than 10, but still half were not. And if you look at the results, you see the overall mortality, that's not too bad, 2.6, unless it's you. The complication of a ventricular septal defect or a hole in the heart going too deep, 2%. It's low, but it's a serious complication. Needing a pacemaker, so affecting the electrical pathways, 9%. Needing further operations on the mitral valve, which should be able to be avoided, 17%. But if you break down the groups, the small volume groups really take up all of those complications. And if you go down to the greater than 10, which isn't still not a very large number, but greater than 10, the mortality is much lower. All the major complications are much lower, and particularly interventions on the other valves. So that's a critical thing to remember why that's important. For that reason, I'm just going to finish up about the team. Some years ago, we developed a comprehensive multidisciplinary team, which involves cardiology, interventional cardiology, electrophysiology, cardiology, general cardiology, cardiac surgery, imaging, and genetic counselling. And this has been basically the basis of the success of the program. And so the methods are quite clear: patient selection, data collection, and analysis. And you can see all the people that are involved there, which is we have excellent meetings every month reviewing all the patients. This is where we presented the data a couple of years ago. So at that stage, it was 150 consecutive patients. It's more than 250 now. And we looked at the ones that went to septal ablation or medications or septomyectomy. And 84% went to septomyectomy after failure of medication at that point, and only 20% at septal ablation. And those numbers are skewed towards surgery. And we looked at those results there. So SM is the surgery, ASA is septal ablation, so it's the interventional. And we looked at the results and looked at this is the baseline characteristics of just how sick they were beforehand. And they were pretty, as you'd expect, the older patients had the interventional procedures. So we might say, on average, we might do that procedure rather than open heart surgery. But that was really the septal ablation was put in the category if we can't operate. The pacemaker rate was right in that ballpark of that experienced units of 4.8, and importantly, septal ablation is a higher pacemaker rate. But overall, the results have been very good, a low ventricular septal defect or hole in the heart, which is repaired nicely. And those incidents are getting smaller because we've had none of those major complications since that data of 2 years ago. So it's actually improving from that. So we've been very happy. This just goes through how well the patients have done, and almost all felt better. And I might say that the septal ablation ones did well as well. But overall, surgery was better. So I'll just summarise. These are all the people. This is only a snapshot of the people that have been involved through all of this. But just to summarise, what we've got going now is a very good surgical program, and we're very proud of that. And it's a great example of what you can achieve if you work collaboratively. But I think what we're going to hear from Sean now, hopefully hear from Sean now, is the work that's going on in the background, which is really where the Baird Institute works to try to improve things in the future, is what research the surgical specimens have been able to enable, and what's on the horizon. So I'll stop there and hand over to Sean and answer any questions you like afterwards. I'll stop sharing at this point, Sean.
Yep, thank you. I'll just bring up my slides. And okay, so Catherine, can you see that slide? Paul?
Yeah, we can see it.
Great, thank you. So thank you, Paul. I guess what Professor Bannon really articulated well there is the clinical problem of hypertrophic cardiomyopathy, and for a percentage of those patients with significant disease with their hypertrophic cardiomyopathy, there is a surgical solution, and otherwise there is good medical therapy. But ultimately, we don't understand at a molecular level what causes hypertrophic cardiomyopathy, what causes the muscle to thicken. We know there are some genetic causes, but there is still so much more work to do. And underpinning that is a need for a research program that comprehensively looks at the heart tissue itself. And ideally looking at different stages of progression of that disease at a molecular level, and then comparing it to other forms of heart failure to see what makes hypertrophic cardiomyopathy so unique. And this really then speaks to the whole point of the Christmas appeal, for which so many of you donors donated generously to this research program. And the research program is really trying to understand in human heart tissue, what is the molecular signature? What are the protein genetic changes that result in hypertrophic cardiomyopathy? And generally speaking, when we talk about cardiovascular disease, which all of you know affects so many Australians, one of the problems with studying cardiovascular disease is it obviously affects the heart, yet the heart is not an easily accessible organ. And a lot of our research in the field has been around imaging, blood markers, clinical markers, so what we call clinical research, which is obviously very important. But to understand what is happening at the level of the pathways and molecules involved, you really need to study the tissue itself. And human heart tissue is difficult to come by. And so one of the aspects that we have relied on are animal models of the heart, for example. And a lot of studies have shown that when you translate what's happening in a mouse to a human in relation to the cardiovascular system, the translation rate or the success of translating those results is probably only 50%. So this is why there is a movement towards human heart tissue models. And with respect to hypertrophic cardiomyopathy, this is really what underpins the basis for our Sydney Heart Bank in collecting tissue from patients who have undergone heart surgery, a myomectomy, and then looking at that tissue to understand the disease. And that really speaks to the whole model for our Centre for Heart Failure and Diseases of the Aorta. And hypertrophic cardiomyopathy is obviously a form of heart failure. And this is really where we're trying to translate what is known before from animal models, but actually now translating that to look at human heart specimens from patients with hypertrophic cardiomyopathy, with the view to understand new potential markers of disease progression, but also understand what causes the disease at a cellular level, because this is the ultimate goal, to translate these findings clinically, not only for better treatments for hypertrophic cardiomyopathy, but the goal always has to be disease prevention, particularly for a disease like hypertrophic cardiomyopathy that affects younger people, has a high incidence in society. Up to 1 in 250 people can be affected. So that's the basis for the Sydney Heart Bank, which obviously includes heart samples from patients not only with hypertrophic cardiomyopathy, but just to give you a bit of background, it's a not-for-profit biobank of human heart tissue, all frozen. It's fully supported by the School of Medical Sciences at the University of Sydney and the Faculty of Medicine and Health, and of course, the Baird Institute. And really, it's the Faculty of Medicine and Health and the Baird Institute that underpin this not-for-profit research resource, which really is a unique resource in the world, because it was the first heart bank to be established back in 1989 through Professor Christos Remedios, who's now an emeritus professor, and the late Victor Chang. And it is the largest biobank in the world with 38,000 cardiovascular samples. And the mission statement is simple. We want to promote collaborative research to understand the molecular basis of human heart failure. And to do that, we have all different heart samples. And again, just to give you some background, we have these historical samples where they were taken at the stage of heart transplantation. So this includes patients with hypertrophic cardiomyopathy that progress to the end disease stage such that they required a heart transplant. And thankfully, with modern day treatments such as beta blockers, and there's also newer treatments such as mavacamten, and also myomectomies performed by surgeons such as Professor Bannon, we see less patients progressing to this end stage. Yet from a research point of view, we need to understand what led to that progression. And so the end stage hypertrophic cardiomyopathy samples that we have in the Sydney Heart Bank are invaluable and are a rare resource today. Now, of course, you can't just have a disease state when you're trying to understand the pathways involved in the disease, because you need something to compare it to. And that's where the donor hearts come in. In the heart bank, we have hearts that for logistical reasons weren't used for heart transplantation, but they are essentially normal. And they act as a great comparator to the disease state of hypertrophic cardiomyopathy to work out what is normal and then, of course, what is abnormal. And that then brings me to what we're currently collecting, and this again relates directly to the appeal, in that the myomectomy tissue, which Professor Bannon has now spoken about in terms of a surgical point of view, that tissue from the operating theatre within 2 minutes is actually taken to our laboratory at the Charles Perkins Centre, which is across the road, if you like, from Royal Prince Alfred Hospital. And within 2 minutes, we can have it cryopreserved and stored within the Sydney Heart Bank. And the benefit of this myomectomy tissue is that in terms of the disease progression, the myomectomies are taken at a stage early on in the disease of hypertrophic cardiomyopathy, whereas the end stage, heart transplantation hypertrophic cardiomyopathy samples are taken at the very end stage of disease. And then you have the donor hearts, which you can compare to say what is normal and therefore what is abnormal in the hypertrophic cardiomyopathy samples. We also have heart failure samples from different forms of heart failure, such as dilated cardiomyopathy, ischemic cardiomyopathy. So at the end of the day, these are hearts that are failing, but they have a different cause. And so using those heart failure samples are also important because it's the same failing heart, but the cause isn't hypertrophic cardiomyopathy. It might be coronary disease, or it might be another genetic abnormality. But they're still useful as comparator groups because it really then hones in on the aspect of hypertrophic cardiomyopathy and the genes that cause hypertrophic cardiomyopathy. And as you're well aware, hypertrophic cardiomyopathy is this thickening, but another form of heart failure is dilated cardiomyopathy, where you can see the cavity size of the left ventricle, your main pumping chamber, is thinned. And interestingly, there can be a progression from this state to this state. And when it results in this state, that's when you require a heart transplant. So that's what I was referring to. End-stage hypertrophic cardiomyopathy actually changes from being thicker walled to something that's more thin and actually not pumping properly. And we don't understand why there is this progression. And in fact, no one has looked at human hearts at a molecular level to understand why this occurs. And that is the very basis of the research program we hope to undertake. So at a cellular level, or when you look under the microscope at someone's heart, there are cardiomyocytes, which are heart cells. And then there is all of this surrounding tissue, which we call the extracellular matrix. And it's made up of other cell types like fibroblasts, endothelial cells. So basically, you've got this web that holds the heart cells in place. And then there are blood vessels that feed all of these cells because, of course, cells need oxygen, and that comes in the form of blood. In hypertrophic cardiomyopathy, the cardiomyocyte, the heart cell, actually thickens. It becomes bigger. It hypertrophies, hence the name hypertrophic cardiomyopathy. So it's not just at the level of the macrovascular, where if you looked at a whole heart and put it on the table, you would see that hypertrophic cardiomyopathy, there is this thickening. But that thickening, if you looked under the microscope, also occurs at the cellular level. But we don't understand why this thickening occurs. And I won't go into detail, but there are different thoughts around why we get this thickening. And it has to do with different cellular mechanisms and different channels within the cardiomyocyte. But what has been underexplored is the potential influence of extracellular matrix cells. So the cells outside of the cardiomyocytes, like fibroblasts, like endothelial cells. So these other cells in this web of the extracellular matrix that may secrete hormones, if you like, that influence and result in the hypertrophy of cardiomyocytes. And simply put, we just don't have enough understanding at the molecular level because we haven't studied enough human heart tissue. So when we look at the tissue that we obtain from patients with heart failure and including from hypertrophic cardiomyopathy, there is a huge array of experiments that we can do. At a very basic level, we can look under the microscope and see how a normal heart looks compared to a heart that has cardiomyopathy, such as dilated cardiomyopathy, where there is a lot of this fibrosis. And even without any knowledge of microscopy and human hearts, you can appreciate that there are more cells here than there are here. There's been a lot of cells that have been lost. And likewise, you can pick up areas of fibrosis, so minimal fibrosis in between these cells because it's a normal heart, and then lots of fibrosis here. And that's what happens with hypertrophic cardiomyopathy. Not only do the cardiomyocytes become thicker, like here, they become more elongated, but also there's more areas of fibrosis between them. And we can even do more sophisticated studies where we can stain for particular proteins of interest and look at how they change. Likewise, we can undertake experiments to sequence the genetics. That's called RNA-seq, which is simply sequencing all the genetic material from the human heart tissue from the patients with hypertrophic cardiomyopathy and understanding what genes are being turned on, what genes are being turned off, how they differ from normal hearts, and of course, that progression from being a hypertrophic cardiomyopathy sample, which is from a patient with normal heart function taken at myomectomy, versus the patient who has progressed to end-stage heart failure with their hypertrophic cardiomyopathy and the result was a heart transplant. So we can also look at all the proteins. And what these are studies which we call multi-omics, because what we're doing is we're sequencing all the proteins, we're sequencing all the enzymes, all within the heart tissue, and we can identify every protein, some 9,000 proteins within a 20 milligram sample of heart tissue. And we can also understand the metabolites, so some 500 different enzymes within the heart tissue. And there's about 10,000 genes that we can look at. So when you put all of this together, you get a huge data set. And then you have to make sense of that data set because you have to link all the pathways involved to try and understand what is biologically relevant. Because it's no good just having one protein change here, one protein change here between a hypertrophic cardiomyopathy heart and a normal heart. What you want to see is multiple proteins or enzymes within the same biological pathway that are changing. That then gives you a clue that this particular pathway may be involved in causing the heart to thicken. And that's the whole research program that we are now going to undertake and relates directly to the appeal. We've done some preliminary work so far, and that's where you don't have to worry about what's in each of these circles. But the point is we have done some protein analysis. We've analyzed about 4,000 proteins between myomectomy samples. So HOCM stands for hypertrophic obstructive cardiomyopathy. As Professor Bannon showed, you've got such thickening of the heart muscle that it's obstructing flow. And that's what the myomectomy samples represent. And then we've looked at those historical samples in the Sydney Heart Bank from patients who have undergone heart transplantation because their hypertrophic cardiomyopathy has progressed to end stage. And we've done the first ever pilot study comparison between these two groups looking at human heart tissue. And what we were able to do was find, as you can see, huge numbers of proteins that significantly changed. So these are the ones after statistical analysis clearly different. And we've been able to group them into different biological pathways. It's not so important what these are, but you can see even in lay terms, there's aspects to do with energy utilization. There's aspects to do with the cytoskeleton proteins, meaning those proteins outside of the heart cells in that diagram that I showed you, inflammation, the immune system. And what we're doing is comparing the signal between those that are unique to the end stage hypertrophic cardiomyopathy versus those that are unique to the more obstructive form, which is further up in the disease process, so it occurs earlier on, and then trying to look at where there is overlap between the two groups. And we're in our very early stages, but our ultimate goal is to try and achieve something which we did previously for a big study that we looked at dilated cardiomyopathy and ischemic cardiomyopathy. So this is not hypertrophic cardiomyopathy, but my point being is we hope to achieve this same level of resource, and I'll just let it play. We've actually created this online as a free research tool to all cardiovascular researchers around the world, where all of those pieces of data from the protein analysis, the enzyme analysis, the gene analysis, so you're looking at probably 5 million data points we have put in a searchable form, working with our colleagues at the School of Mathematics at the University of Sydney, such that a researcher can log on here and look at a particular protein or metabolite of interest and then see how did it change in different forms of heart failure? They can then create these network maps to see how does that particular protein or metabolite interact with other proteins or metabolites? Because as I said, it's not just about one protein, it's about how it all works together in a biological pathway. And that's the key to understanding what causes a disease. And we hope to create a similar such map that can be used as a research tool once we have undertaken these analyses that we propose, looking at not only the myomectomy tissue, but also the end-stage hypertrophic cardiomyopathy tissue. And as I've just shown you, we've begun that process, and we hope to give you an update perhaps in 8 to 12 months' time. So I'll leave it there and hand back to Catherine.
Great, thanks, Sean and Paul. Fascinating stuff. Wondering if we've got any questions. We don't seem to have any put through on the Q&A, but if you want to do the raise your hand, which is at the top, there's a little hand that says raise. Or maybe, Daria, we could just unmute everybody, and anyone wants to ask a question, they could just speak up. Could you do that, Daria? Is that possible?
We do have one question.
Oh, you do have one question. Okay.
Yeah, in the Q&A.
Maybe you'd like to, do you want to read it out?
So Ron is asking, hypertension, how critical is this considered as an etiological factor in heart failure?
Did you get that, Paul and Paul?
Yeah,
Paul and Sean?
yeah, I'm happy to answer that. So hypertension or high blood pressure today doesn't directly, or it's very unlikely to directly cause heart failure, because today, with such excellent, proactive general practitioners and people having better health awareness, most hypertension or high blood pressure is diagnosed fairly early. And because we have such an array of medications to treat high blood pressure, it is generally well treated. And the days of sort of having untreated severe high blood pressure that takes such a toll on the heart that it thickens because the heart's pumping into this higher pressure, and then after thickening it actually fails, that whole sequence of events is quite rare. But when you have existing heart failure, if it's hypertrophic cardiomyopathy, which is of course largely genetic in origin, dilated cardiomyopathy where the heart enlarges and thins, which is also genetic in origin, but it can also occur if you have coronary artery disease. With those forms of heart failure, if you add an insult of hypertension or high blood pressure to that, it makes the heart failure worse. The simple way to think of it, the heart's a pump, and if the pump is already failing because of other causes, and then you raise the pressure into which it is pumping, it's going to fail. So it is critical to have really good control of blood pressure if you have underlying heart failure.
Sorry, my microphone was off. Thanks for that, Sean. Was there the person who asked that question? Did you have any further question of Sean or Paul on your original question? But I think Dari is trying to unmute people, but I don't know. They seem to be all muted to me.
So people can individually unmute themselves now if they want to talk.
Oh, okay, if they want to speak. Any other questions? Nobody else? Was that Dennis? Oh, somebody's here.
I haven't got a question about that, but I'm a bit sorry because I didn't get Dr. Bannon's photograph parts. I got him speaking, but I didn't get his what he was showing on the screen, which I was disappointed about because I have had a myomectomy, and I was just interested to see all what happened.
I can send that.
I'll we can do that.
Talk. But I'll send you a recording of the event afterwards. But also, if you'd like to just see it as a PDF, we can get that and send to you as well, right, Paul?
Okay.
Yeah, absolutely. No, you have it all. Yeah, absolutely.
Thank you. Thanks very much. That'll be great.
No worries. Dennis, were you wanting to say something? I feel that you had unmuted yourself, maybe. No, or Stephen, you're unmuted. Were you interested in saying something, Stephen Catterus?
Oh no, not just at the
No,
moment.
that's okay. No worries. Anybody else? No, we don't have to have questions. It means it's all been explained very well, obviously. But yeah, I don't know. Did Sean or Paul have anything further to say?
I just say that summary of Sean's as to why we do the research is excellent, because, as a surgeon, we should be, if we're really actually doing our job right, we should be looking, as an academic surgeon, I guess, as a research surgeon, we should be looking for ways to replace us in the future, and that because everything comes at a cost. Open heart surgery is a big thing for patients, and we're always looking for less invasive ways of doing things. But even the new drug trials, which are promising, still have downsides. So the only way to get away from all of that is to understand the mechanics or the basic reason that these conditions occur, and you have to do that at the molecular level that Sean's outlined. So, it's a great honour for me to be able to work with everybody to be able to do this. And if my legacy is everything, once I stop operating, it's that I'm redundant, and I hope that's the case. My kids probably think that anyway, but I'm sure they do. I'm sure they do. But thankfully, I haven't given them a link to this webinar. But but I think any message you take away from this is not really the surgery, because that's the best thing we've got now. But all research should be comparing, what the gold standard to the next best gold standard. It should, and that's what we're trying to do, I guess, and we're trying to get to that.
Mm-hmm.
Yes, and I would just echo those sentiments by Paul, and just also highlight the fact that what we're trying to create, or what we have created in having a centre where we link the basic research all the way through to clinical. And I would say that it's our job as physicians, as doctors, not only, of course, to treat patients and to take that responsibility, but to also understand why the disease occurs in the first place. And that's the very notion behind the concept of a physician scientist, so being dual trained as a scientist and as a clinician, because you're in a position to at least attempt to answer those questions, and it may not be answered in one's lifetime, but the point is to set that in place. And we have that set up quite nicely with the Centre for Heart Failure and Diseases of the Aorta, and it will only grow.
Yep.
I agree.
Excellent. Well, I think that's it. Unless there's any last minute questions, I think we're right. But thanks all for coming along today. I will send out within the next week, a recording of the event. There are lots of other people who had registered for the event, but obviously middle of the day doesn't suit lots of people, but at least they can get a recording of the event. But obviously all of this research, or majority of this research, is happening because of all of your support and all of the donors to the Baird Institute. So we're really grateful for that. But thanks for coming along today, and we'll see you at our next event. We do have Paul is participating in an international aortic webinar in a couple of, it's in May. So I'll send out information on that for anybody who wants to participate in that, but it's called Taking Care of Your Aorta, and we've got some Americans, and as well as Professor Bannon and another cardiologist who has a special interest in aortic disease. That's going to be happening on the 8th of May. I'll send out information on that, and again, you'll be able to get a recording after the event if you can't attend on the day. But thanks all very much for coming along. Thanks to Paul and Sean for presenting today, and just to explain to you where your money is going. I think it makes it better for everybody when they know, or can see the evidence of their impact anyway.
Yeah. Thank you for anyway. It's
Thanks.
been very informative. Thank
Thanks.
you.
Great.
Yeah, thanks, Catherine and Daria.
No
Thank
worries.
you.
Bye-bye all. See
Bye.
you.
See you guys.
Bye.
See you guys.